So welcome everybody. Thank you all for joining us today, which is part of our, thank you for joining us for today's webinar, I should say, which is part of our webinar series funded by the Australian Government Department of Health, Disability and Ageing. And if you've joined us before, welcome back. You'll already know that what these webinars and webinar series is all about, how to apply evidence into practice, which is part of our comorbidity project. My name is Christina Morell. I'm an Associate Professor and Deputy Director of Treatment and Translation Research at the Matilda Centre for Research in Mental Health and Substance Use here at the University of Sydney, where I also lead this project. And I'm so very pleased to be here today, joined by other members of my team as we bring you part one of a two-part special webinar series, which is focused on domestic and family violence. Before we go any further, I would like to acknowledge and pay respects to the traditional owners of country on which we're meeting today and recognise that we are all joining from many different lands. I'm joining from beautiful Gadigal lands today, and I would like to recognise their continuing connection to land, waters and skies, and acknowledge the same for the lands that you're all joining from, and pay respects to elders past, present and emerging, as well as any Aboriginal and Torres Strait Islander people who are joining today. I'd also like to recognise and acknowledge the many people with lived and living experience of mental health conditions and substance use, as well as their families, carers, loved ones, and chosen families, many of whom have been involved in our project and the development of our resources over so many years. You'll all know to please use the Q&A button for questions for our presenter, Sophie, and to please use the chat for any comments or anything other than questions. I know this sounds very nitpicky, but if this just helps us in our team and in the back end here keep track of what we're passing or keeping aside in our Q&A discussion, and whether there are any requests for support or technical issues that we need to be jumping in with to assist. So thank you for that. And we will be making the recording and handouts for today available from our website in the next few days or early next week. If you find Zoom chat annoying or distracting, you can have a play around with the settings on your end to disable what messages you see. Our team, I think, will be posting that link in the chat if you want to have a play around with it later. So today is part one in our two-part special series focusing on domestic and family violence. We recommend that you attend both or watch them later if you're not able to come to the live stream. Part one today will be focusing on navigating the intersection of domestic and family violence and alcohol and other drug services practice considerations for staff. And part two, which will be held in a few weeks on the 26th of August, Rodney Vlase will be considering how to engage adult users of domestic and family violence, concepts, roles and practice tips. The link to register for that one, if you haven't already, is on screen, and we'll also post that link in the chat. Both of those webinars are 90 minutes instead of our usual 1 hour, and we're hoping this will just give us a little bit more time. So if you're having to duck out early, you can catch up on the recordings, which will be posted on our website. For those of you who are practitioners, Sophie and Rodney will be holding a follow-up panel discussion in our online community of practice in September. You can find out more information about that community of practice at our website. If you have a few minutes at the end of our session today, please share any feedback about our series. We do read everything that you send through, so thank you so much for taking the time to do that. Now it's my very great pleasure to introduce our presenter for today, Associate Professor Sophie Isobel. Sophie is an Associate Professor of Mental Health here at the University of Sydney and has a clinical background in mental health nursing. She's worked within health services for over 20 years, advocating for trauma-informed approaches for people experiencing distress and their families. I have to say that we've been working on putting together this series for at least the last 18 months. So thank you to our friends and collaborators who have helped make this happen as well. There's been a lot happening behind the scenes, and I can't tell you how pleased I am to be able to have Sophie here today and Rodney in a few weeks. So no pressure, Sophie. So thank you so much, and I'll hand over to you to get started when you're ready.
Thank you so much. I'm really honoured to be here today. I'm going to share my slides. Just click. Thank you everyone for making time to join. I'm going to be speaking about practice considerations, so trying to think about for staff working in AOD services or aligned services who are also engaging and supporting people who may be experiencing violence. It's not an easy topic to sit and listen to as a webinar, although I won't be explaining or talking about experiences of violence in any detail, but I do encourage you to look after yourself throughout and do something nice afterwards, even if it's just a stretch and a cup of tea. I think when we work in services that work with difficult things, substance use or mental health or violence, that we can start to think that things don't impact us, but really sitting with the dynamics and impacts of violence does impact us, and as it should in a way. I don't think it's something we should become immune to, but I also don't want to ignore that. So please do whatever you need to do to look after yourself throughout this and afterwards. Get my clicking technique down here. There we go. I also want to recognise and pay respect to the traditional owners of the land. I am zooming today from Gadigal land in the inner west of Sydney, where I work and live and walk. And in the context of what we're talking about today, want to also acknowledge the disproportionate impacts of violence and substance use in Indigenous people's lives, families and communities as an ongoing impact of colonisation, and the structural violence that occurs within systems and services. But I also want to acknowledge the many thousands of years of wisdom and knowledge held by Indigenous communities, particularly around healing and safety and trauma in the context of today's topic, that I've learnt so much in my own work from Aboriginal people and communities who've generously shared knowledge around trauma and healing that has also informed this work here today. A little bit about me. I am a mental health nurse and more recently an academic. When I was first talking to the Matilda Centre team about this webinar, I felt a little bit like, oh, I'm not the right person because I don't work in AOD services. And they were very kind to me and generous in supporting me to come around to sharing this webinar, on the basis that a lot of the folks listening here work in AOD services. So you bring that knowledge, and I bring, I guess, an understanding of how tricky some of this work can be. I've been working in mental health services for most of my career as a clinician. And although when I started, mental health and AOD services were one, so I did spend 6 months in substance use service as a new graduate nurse. And in my work as an academic, I've been working with a lot of different services and settings and systems around what does it mean to be trauma-informed in those spaces. And that is what led me into work in the domestic and family violence space specifically. And for the last couple of years, I was doing a really big project with PAVAN, so the Violence, Abuse and Neglect part of the ministry here in New South Wales, around domestic violence screening and responses in health services. And from that project, I went around the state and met with a lot of workers in all sorts of different settings where routine screening occurs, so mental health, child and family, maternity and AOD services in metro and regional settings in New South Wales. And so I'm bringing the voices of those workers into this space, the things that people told me about their experiences of working with people experiencing violence in their services. And the other part of that project was working with a group of 34 women who experienced violence, around developing some resources and understanding what women experiencing violence would want from health services. So I guess I'm really drawing on those stories that I've held and heard and the experiences of those folks in talking to you today. I've been really interested in the relational element, so what happens in the moments when we work with people who experience violence. So acknowledging the wider context and limitations, that there is an under-recognition and an under-funding of both domestic and family violence services and AOD services. And so that there's a lot of limitations and things that get in the way of us responding and providing care to people in the way that we would like to or wish that we could. But I have sort of zoomed my mind in to think about, well, what is possible within the limitations? What are the relational things that we can do in engaging with people that make a really big difference in trying to create a safe enough approach to the way that we deliver care to people? And a lot of that also relies on us having enough understanding of the dynamics of violence that we can use that understanding to shape the ways that we interact with people and the care that we deliver, whatever form that takes. As was mentioned, this is the first in the two-part series. And so I encourage you to attend Rodney's webinar as well, working with people who use violence. I'm going to talk about, I guess, to reflect on some of the challenges and possibilities of responding effectively or safely to domestic and family violence within existing service delivery. So not about how we can be domestic and family violence specialists, although there may be some domestic and family violence specialists online who can help answer questions around that as well. Are we really drawing on those lived experiences that people have shared through that big project with the ministry? And then I guess thinking about how I understand what it means to be trauma and violence informed in the work that we do. So we hear a lot about being trauma informed in lots of different policies and practice documents and things, but what does this really mean in the context of working with people experiencing violence within AOD services? Definitely can't do it all in a webinar, but wanting to introduce some of these ideas. And also part of the idea with the two-part series was to introduce, I guess, to position some of the understanding around AOD and domestic and family violence. So I'm going to spend a little bit of time first talking about the intersection before moving into how to navigate it. So thinking first about, excuse me, guess setting the scene. How am I talking about domestic and family violence, and why am I talking about it that way? And you might have heard already that I'm using gendered language, so talking about women who experience violence, and that can be quite uncomfortable and confronting for many of us in mental health services. And in my work in those areas, I've really moved away from using gendered language because, as we know, understandings and talking about gender have changed. And for many people, gendered language is limiting, but also potentially hurtful and harmful. So I acknowledge that, and I want to explain the intentionality of that in the kind of space of domestic and family violence, there's a really intentional retention on gendered language. And that is because domestic and family violence is rooted in gender inequality and social structures that have long privileged men's power and control over women. So the use of the gendered language is to hold that awareness alongside when we're talking about individuals' experiences. But it isn't to discredit or invisibilize the experiences of people who are not women or who don't identify as women who experience violence. That anyone can experience domestic and family violence in any type of relationship. And whenever I give a talk about this topic, nearly every time somebody would ask a question about, well, what about men? Why are we ignoring men who experience violence? So I want to be very clear in my positioning up front that I am not ignoring men who experience violence or people of diverse genders who experience violence. Domestic and family violence occurs in queer and gay relationships. It impacts people of all genders, and men certainly do experience violence. And those are all areas that require attention and are of importance. But the language is trying to hold on to that awareness of the wider social context, the kind of social systems that normalize male entitlement and control and unequal power relations. And I think that is important when we're thinking about the practice considerations, because it helps to understand some of the dynamics like coercive control or why people stay in violent relationships when we're aware of the wider kind of social context and positioning. So all language is imperfect. I will be talking about women who experience violence, and there's a general consensus or an agreement that women who experience violence are often referred to as victim survivors. And that is not a term that everyone likes or suits everybody's identity, but I will be using that term throughout. And also, even the language of domestic and family violence. So that includes IPV and DV and other kind of terms that have been used to talk about violence within intimate relationships. But the kind of movement has been to widen the term to domestic and family violence to acknowledge variations in relationships and kin and family units. But keeping a focus on the kind of dynamics of those really close interpersonal relationships that we have within domestic partnerships or family units. There is a little bit of a move to widen that again to domestic, family, and sexual violence. And I'm open to shifting and changing language, but just sticking with domestic and family violence at the moment, with recognition that sexual violence certainly can be a component of that. So that's my language summary, and I think that starts to lead into how I'm thinking about and understanding violence in this space. I'm going to put up this power and control wheel that is widely used across domestic and family violence, and I think is really helpful in thinking that this isn't about individual incidents or assaults, although those are a big part of domestic and family violence for some folks, but that domestic and family violence is understood as a pattern of domination. So, and power and control are at the center of that. And there are lots of ways that that plays out in people's lives. And we focus very much in services sometimes, in the legal system, certainly up until recently in law, on discrete episodes of physical or sexual violence. Whereas for a lot of people, these elements that are in the kind of white or light purple sections of these circle are the things that get harder to identify as violence, but incredibly life impacting. And in the last few years in New South Wales and in other states as well, that coercive control has become recognised in law, which is a big step in moving away from thinking of violence as episodic. But it also shouldn't hide the fact that coercive control always exists as part of domestic and family violence. And this is what sustains and enables violence. And so that includes things on this wheel around surveillance and intimidation and isolation, and relevantly for us today, about substance use coercion as well. Many women experience multiple types of violence rather than one type, one discrete type during their lifetime. I think in one Anne Rose study, out of 900 women who experienced physical violence, over 60% experienced technology-facilitated abuse, and 40% financial abuse as well. And for many people who experience violence, they may also have experienced violence at different points in their life. So there's a correlation between experiencing violence in childhood and experiencing violence in adulthood. And I guess there's ways to understand that around normalization or familiarity of experiences of coercion, fear, and unpredictability, secondary disadvantages that can occur, as well as targeting of folks who have some existing vulnerabilities by perpetrators. But I think it's important to be clear that domestic and family violence is caused by perpetrators' behaviour, not characteristics of the victim survivor. I guess there's a thought I'm thinking I want to say around that as well, that there is, and probably this will come up in Rodney's webinar in a few weeks, but there is this idea or a phrase that gets said around, hurt people hurt people. And I also want to be clear that most people who experience childhood abuse do not become victims or perpetrators of DFV in their adulthood. And so it can be a slightly problematic space when research starts drawing correlations between other things that have happened in our lives and violence. But I think important to recognise the intersectional disadvantage that many people experience alongside violence. I think we are increasingly sort of getting conscious and aware of the importance of doing something around domestic and family violence. But that awareness has also fluctuated and existed over a very long period of time. So we see patches of media content and coverage and political gestures towards domestic and family violence, but it's a very pervasive and sustained issue in Australian society. Currently, police respond to a domestic and family violence call out every 2 minutes, and 1 woman a week approximately is killed by a current or former partner. I think the current data is about 1 in 6 women have experienced violence by a current or former partner in their lifetime, and that it's the leading cause of homelessness for women and children. There's also, I think, important to recognise a really significant lack of services, which means that there's an underreporting of violence, that people aren't always seeking help. It's not always safe to seek help for domestic and family violence because we have fluctuating funding. So services get funded for a while and then they lose their funding, and then a new big shiny service gets opened, and there's this kind of disconnect of holding and building in this space, even though there are incredible people, of course, holding and building in this space, often without the resources and support that they need structurally. And so there can be a real focus on people experiencing violence and what are they doing and why are they staying in relationships where there's violence, or what is the vulnerability that leads to them being in these relationships, as opposed to a focus on what are we doing structurally and within systems and services and as a society to alter responses to and acceptance of violence within relationships. And I think that that has relevance to our practice, because it sometimes can feel like, I think when I was working in health services, that my responsibility around violence was to ask about it as required and document it and refer people to services. And it's so much more than that, I guess. And I think you're all here at this webinar because you know that and you think that and you have thoughts around that. But we still a long way from really integrating that knowledge into all of practice around what can we do to support people while they're accessing services, and what is a good response, in that there's still a focus in society, I think, of why people don't leave relationships or helping people to leave violent relationships, whereas that is not always people's desired outcome or even the most safe thing for people. So it's, I guess, thinking a little bit differently around the elements of power and control that underpin domestic and family violence, as well as the social context that disempowers people experiencing violence, that then kind of compounds into people accessing our services and us feeling complex, competing experiences of how we can help. The intersection with AOD, I feel there's no need for me to tell a webinar of AOD workers interested in domestic and family violence that there is an intersection, but just a quick kind of summary of the research, that women with histories or current domestic and family violence are around 2 to 4 times more likely to use substance than women without those experiences. And that can be a response to violence, so a coping mechanism or an adaptation, rather than a risk factor. But as I mentioned, perpetrators of violence may also target people with vulnerabilities such as substance use or AOD use in their sort of partner selection. And that also the rates of women accessing AOD services who have experienced or are experiencing violence are really high. So a recent narrative review of literature found that between 25 to 75% in some studies of women accessing AOD services experience violence. I think something that struck me in working with AOD workers around this was the diversity of age and demographics of women in those services that experience violence. There's probably more of a focus on in maternity or child and family, sort of young women at that childbearing age, or whereas in AOD settings, of course, it could be much older women or much younger people as well. So it doesn't necessarily change our response, but again, I guess sort of challenges that assumption or presumption of who we think might be experiencing violence. And certainly there's some really powerful narratives of particularly older women and their further kind of ageist invisibilization that can happen of their experiences. We know that when AOD use is involved, that experiences of violence are more severe, and also that when there's violence, substance use can be amplified as a way to survive or cope. And relevant to our conversation today, that the AOD use or substance use, and sorry for quick switching terms and if they're not the term that you prefer, but that can be interwoven with violence, so that people may be pressured by a partner to use substances as part of the dynamics of violence. Recovery attempts can be sabotaged. People may be in dependent kind of supplying relationships with someone who also uses violence, and that people can use a victim survivor substance use to undermine credibility or to justify abuse as part of the domestic and family violence. And then that becomes complicated for us, that we sort of trying to navigate this, what's happening in this dynamic. And in AOD services, of course, sometimes you're providing care to both the victim survivor and the perpetrator, which brings some additional complexities that I'll talk about in a minute. I think one other sort of particular challenge or barrier is, of course, that there's already limited services for women experiencing domestic and family violence. And then some of those have a requirement of abstinence as part of access. So you can't get help with domestic and family violence until you stop using, but stopping using may put you at further risk from domestic and family violence. So it's, I think, why am I pointing out challenges that you probably already experience in your work? I think trying to acknowledge the unique elements of this in AOD services and the intersectional struggles of trying to support people in effective ways with really systemic and structural barriers to that. I mentioned about AOD use being part of violence, and I think that it makes sense in the context of thinking about that power and control, that perpetrators of violence may also use substance use to gain more power, so to excuse their violence, to kind of block out memories or verbalizing experiences of violence, to shift the focus. And we see this in the media, from being charged with domestic and family violence to saying it's from because you have a substance use problem, and also to control others with their substance use, and weaponizing substance use against victim survivors. So then I think as AOD workers stepping into these complex dynamics and trying to unravel them or understand them is a really big ask, as people who use violence are often very good at manipulation and control. And that can be confronting, I think, to us as workers in these spaces. I'm thinking about in my clinical background in mental health, I think mental health clinicians, we like to think that we can see kind of through people's personality structures or ways of interacting, and kind of know when we're being manipulated or something, but it's very confronting to accept that we can also be groomed in services as part of violence, so that we start to become confused about who really is the victim, or how reliable people are in their stories that they're telling us, or just getting an element of uncertainty in there that helps to kind of undermine victim survivors' experiences. And so it's not for us to have to again, be domestic and family violence specialists, that we are expected to step in and understand the complex dynamics. I think the more important thing is that we're aware that the dynamics are complex, and we're able to sort of hover back a little bit and keep reflecting on ourselves and what might be happening here, and why we're responding to people in these ways, rather than just sort of taking things at face value, or presuming that we understand what's happening for people. I do want to highlight that the intersection that I'm talking about in this webinar between AOD use and domestic and family violence is really not a neat and tidy one. So that, as you would know, the dynamics of AOD use are complex, and people are experiencing often ambivalence and hope and hopelessness, and the interactions of substance use with relationships and lifestyles and domestic and family violence can also be like this. So it's often confronting for people not in relationships where there is violence to appreciate that there can be love alongside violence, or good bits of relationships alongside really horrendous bits, and that many people have really complicated worries and ambivalence and unwillingness about leaving, and that it's a burden sometimes to encounter health workers or other people's judgments around that. As well, that the dynamics of power and control confuse people. That's what they exist to do. They erode self-worth until we may be confused about what is love, or whether this relationship is crucial for our survival, or maybe I caused this to happen somehow. That kind of undermining of being able to see things clearly, or to understand what's happening clearly, is part of the dynamics. So then we can't come in, or services can't come in as hero workers who sort of sniff out experiences of violence like a truffle and help people leave. That violence doesn't work like that. That many people may not yet be willing or able to leave, and instead we're working with supporting people within dynamics that are scary and hard to understand, and that sometimes there isn't, or it can feel like there isn't anything we can do necessarily. And I think the other element of this complexity that I don't want to downplay is that it can seem like practice responses should be really straightforward. And I guess I've encountered this a lot in my work around trauma-informed approaches more broadly, that we, the kind of collective we of workers, like to picture trauma survivors or people who experience trauma as vulnerable people in need of saving, and it's easier to have compassion for people whose experiences of trauma show up as fear or sadness rather than anger or prickliness, or but in reality, part of the dynamics of trauma, and in particular domestic and family violence, are that often we're providing care to people who may be more evasive or tricky to engage, or potentially some of our most challenging kind of clientele. And so being trauma informed rarely means that we just have an understanding of trauma. We make people feel safe by our fabulous interpersonal skills, and then interactions go really smoothly from there. I think my understanding of being trauma informed is much more around extending to all folks, not just those interactions that make us feel good at our jobs. And people living with violence will often not turn up to services or change their stories or decline help or protect the perpetrator or at times enact violence themselves. And this is part of the dynamics that they're living with and uncomfortable, I think, in services for us to make sense of and sit with. Our services are very much set up to disconnect these issues, as I'm sure you experience that, you know, if somebody's experiencing AOD use, we refer them to AOD services. If somebody's experiencing domestic and family violence, we refer to domestic and family violence services. Whereas all of our lives are much more messy than that and interwoven, and that these issues coexist and often, in fact, cluster together and interact, so that people may be experiencing mental health challenges, homelessness, substance use, and violence all at once. And so, even though our services are compartmentalizing within our work, we're trying to think about what does this mean? So, how can we provide existing care to people where there is violence, and how does it change that care? And I think sometimes it changes it in ways that are unhelpful. So I'm thinking about, for example, in a mental health service that I worked in for a while, we had a new home visiting policy, which meant that, you know, there's this list of things, and if people have these things in their lives, then we no longer home visit. And it might be a big scary dog, but it's also experiences of domestic and family violence. And while that policy existed to try to keep staff safe, the impact of it is if you tell us about your experiences of domestic and family violence, you will get reduced service. So there's a immediate kind of active structural violence that occurs, which further isolates victim survivors. So the understanding the intersection is kind of complex. What are the ways that our policies reenact violence? What's my obligation to know how to link to services? What are the services within my local area that support domestic and family violence, people experiencing domestic and family violence, and particularly which are the local ones that accept people who also use substances or can have their children present with them while accessing those services, as well as what do I need to think about in the way that I'm engaging with people. And I think probably most of the navigating that I'm going to be talking about in this webinar, I am already talking about in this webinar, in fact, is around that within our existing roles. So recognizing this context, but what are the things that I need to do relationally in my interactions with people? The other final thing I want to acknowledge in this kind of talking about the intersection is staff's experiences of violence. So there isn't a clear delineation between people who experience or use violence and health workers. Health workers are known to experience domestic and family violence at much higher rates than the general population. I think in 2018 study in Victoria put the prevalence rate of domestic and family violence at around 45% amongst female healthcare workers. And that not all of that is current or recent, but quite a large amount of it was, which is much more than the Australian Bureau of Statistics estimates of 27% of lifetime exposure amongst Australian women. And those prevalence rates have been reported across studies that many female healthcare workers have experienced violence in their life. And certainly in our co-design work, many of the victim survivors who we worked with also held roles as advocates or workers within services or health workers. And many of the staff that I met with in the kind of staff consultation also shared their experiences of violence in their lives. I think the other confronting component of this is that, of course, health workers will also be perpetrators of violence. And when we're sitting in trainings or conversations or professional development around domestic and family violence, it's very confronting to sit with that idea that some of those perpetrators are also workers within services. in meeting with AOD workers, staff really talked about their concerns about violence as well. So especially in rural areas or smaller communities or specialist teams, or when both people in the partnership are clients of the service, that staff experience concerns for their own safety when people disclose violence, to the point that sometimes they didn't want to know, like they didn't want to be told that their client was experiencing violence, because it put them in a tricky spot of holding that information and being really concerned for their own safety, because of the strategy and manipulation of perpetrators, because of the way that services can get used as part of structural violence against people, and also just the visibility, particularly in smaller rural areas or specialist teams, of knowing a perpetrator, knowing that you know what's happening. And then there's the vicarious, I think, experiences of violence. So the distress of hearing people's stories or not knowing how to help, or a reactivation of our own experiences of violence. So all of these dynamics I'm talking about come into play in this intersection, where often in service policies or practice guides, we might be asked to ask clients about violence, or respond compassionately when people tell us about violence, or prioritize safety, or these kind of phrases which are well-intentioned, and of course what we should be doing, but the complexity of what we're navigating when we're trying to do those things doesn't often get sat with and unpacked. So, my clicking stopped working. So yeah, now I want to talk about navigating the intersection, I guess, some of the ideas I have around navigating this in practice, and drawing on the experiences people have shared with me. I want to start with this quote that a woman experiencing violence shared during our consultation. And she really equated talking about her experiences of violence as having a pap smear on the outside, which I think is just something for us to hold, that sometimes when we work in services, AOD or mental health or other services like that, that it can become almost normalized to have conversations and hear about violence, or to ask people about really personal experiences of their life, a bit like perhaps it becomes normalized for a sexual health nurse or a GP to do pap smears, and it's not a really distressing and intrusive experience because it's so normalized to them. But for women experiencing violence, the stakes of these conversations, or the holding of knowledge about their experiences of violence, are really high. So the shame that people feel, the fear, and I think also the burden of inadequate responses. So that the times where we ask or people tell us about violence and we document it, but we don't really come back to that conversation or acknowledge the role that this plays in people's lives or their substance use, because we feel uncomfortable, or we don't know how to help, or we think they don't want us to talk about it again, feels like a large burden for people to carry. And I think that's really important whenever we're thinking about engaging with and asking people or responding to experiences of violence. In New South Wales, and I know I saw from all the little hellos popping up that people are from all over Australia, and there's different approaches to routine screening, but in New South Wales, it's mandated in domestic and family violence, in AOD services within New South Wales Health, to ask about violence, which means that theoretically all women accessing health-based AOD services will be asked about their current or historical experiences of violence. And that is really important for a few reasons, and also quite challenging for a few reasons. So in some of that work I was talking about, of going around the state meeting with health workers, I heard that people didn't really understand that. Like, why are we asking all women that? Is this about the Ministry of Health gathering stats and data about how big the problem is? Or confusing ideas about why we're asking. But the reality of that is that it's a public health approach. So in the same way that we would offer, I guess pap smears again is another example that, if women of us, people who identify as women or people who have cervixes of a certain age, all have routine pap smears at certain points, then we're more likely to detect those forms of cancer. Whereas, so if we ask women at specific service settings about their experience of violence, we're providing the most opportunity to identify and potentially offer support for people experiencing violence. But of course, that isn't the only time that we have these conversations. And I think in AOD services, in fact, routine screening is often not when we're having these conversations, that routine screening might occur as part of an assessment, or it may not occur at all because we don't have the computer in front of us that has the screening tool on it. Or it's not the safest point when people are first coming into contact with services. And particularly in AOD settings or mental health services, that can be when they're in withdrawal or still actively using, or in heightened states of distress, and there isn't the trust and rapport to have those conversations about violence. So I think there's the two things can be true at once, that routine screening is really important for providing opportunities to normalize conversations about violence, to keep it in the collective mind of workers as something that's important. But it can become a sort of tick the box exercise. And we know that often these conversations need to be woven into care when there's a lot more trust and rapport that's been established. And that people may feel very uneasy responding honestly to questions about violence when they're first meeting a person or a service. And so women who experience violence definitely indicate that there's a lot of, I can't think of the right word, like thinking and decision making that happens around when you disclose and to who. And so when you're coming into contact with a service for a particular need, you may not want to have all of your other needs addressed at the same time. Plus, of course, those other systemic issues that I've mentioned impact upon staff's engagement with routine screening. The sense that, well, if I ask these questions and somebody tells me about violence, what am I going to do? I don't know what services to refer to. I don't know how to respond. So I won't answer. I think it's important to sort of think routine screening plays a role, but weaving in conversations about violence into care and in ways that suit your setting and your way of delivering care, and the level of trust and rapport that's possible within the type of relationship that you might have with people is really important. In I guess the work that we were doing around the screening, what became really clear was the clumping together of these lots of moments into one moment, that we'd sort of talk about when are people asking about violence, when are we addressing violence, whereas actually often when you break this down, there's a lot of little moments that are going on there. And as workers, we're often busy and we've got lots of competing demands. And if we leap straight from somebody's told us about experience of violence to what do I need to do about that, then we miss all of these important, actually crucial kind of moments in between somebody telling us about violence and us actually doing anything in terms of referring to a service. And in fact, I would think that these relational actions that we do are often the most crucial in terms of doing and supporting people accessing our services. So, if we think about it as I'm a bit bothered by my arrow direction there, but that if if somebody was to tell us about violence, and we start with a validation and belief, and then from there moving into offering collaboration and support, and from there into advocacy and referral, it slows down our own distress around this as well. That sometimes I think of my like mental health clinician brain as this sort of matrix. Like somebody tells me this, okay, that means I have to do this, and then I have to do that, and then I have to do this, and what does that mean for that? Whereas we can skip past what's happening with my face and like what are my eyes doing when somebody's telling me this, and what do I need to do to really signal to this person that I've heard what they've told me and it's really important, and that we can figure out together what we're going to do about this. And that I feel that there isn't enough attention on those relational elements in all of our workplaces around how do we make people feel a little bit safer in these things that they're telling us. Not necessarily safe. It's not possible to make people feel safe when they're telling us about violence in a health setting or in a service setting, because we're actually asking them to do something quite risky, which is to talk about something in their life that is a real threat to them. And then we become part of that because they're needing to trust us to respond safely, to keep their details, or to be careful with what we write, to be careful how we share that information, to make sure that the person using violence doesn't know that they've told us, that we respond in helpful ways rather than unhelpful ways. And there's a loss of control that happens, whereas we know that women experiencing violence are often doing many things every day to keep themselves safe or to keep them and their children safe. And in bringing others into that space, whether that's individuals or services, there's a compromising of that system of safety that they're constructing for themselves. So I guess I have, in my work, really tried to zoom back into that. Like, what are the things that I need to do in the immediate response before I leap into action, before I activate a matrix of things that I need to do? And again, holding that knowledge of the dynamics of violence in that moment is really important, because if I leap into action and, okay, this is what I'm going to do and this is what I'm going to share that information with, and it's actually potentially reenacting kind of dynamics of power and control, which is really a distressing thing to say, I think, because none of us would want to be thinking that we're doing that. But disempowering people who are experiencing violence because we're going to help them becomes another form of violence. So really slowing down and thinking about our response and ensuring that we move at the pace of the person sharing their experience, and that we're going along together as much as possible. And when there are things that we need to do as workers for whatever obligation, that we're as transparent as possible about that with the person receiving care. So there's a lot going on in these little moments, I think, as health workers or as workers in services. We're navigating worries about, what does this mean for my obligations of if you need to mandatory report around safety or children, but also what does this mean for my engagement with this person? How does this change the sort of care or treatment or way that we deliver service? Who do I need to tell? What do I need to document? Do I know enough? Do I know how to support this person? And at the same time, the person disclosing violence is juggling their own fear and mistrust and expectations, and very attuned usually to how is this person responding? What sort of judgment might they be making about me? What things might happen now? So I think we all know that how people make us feel in relationships, and by that I mean kind of service relationships, whether it's going to a GP or walking into the pharmacy or going into a service, or we read the feeling that we have with people, and we can either feel safer or less safe from the way that they interact with us. And I think in the space of providing care to people experiencing violence, being really attentive to our own, I can't think of a better word than vibe, like what are we bringing to that interaction and to that relationship is really crucial. When working with victim survivors, we sort of broke down some of this initial response to what people want in those moments. And certainly not every dot point here will be relevant to your context. But that kind of thinking about what do I need to do first? So acknowledging what this person is telling me. And that can be sentences like, I'm really glad that you told me that, or the kind of the validation of this can be really scary to talk about. So it doesn't necessarily have to be something that feels unnatural, but the making sure that we don't forget to acknowledge how important it is that somebody's told us about experiences of violence in their lives, which is different to telling us about other things that we ask people when they come into services. Have you ever had this? Have you ever done that? That often the fear and the implications for safety of violence are really ongoing and present in people's lives. So taking the time to acknowledge and validate that, and pacing that disclosure together, like what is important for me to know? What are the things that it's important that you tell me, so that we're not going, okay, this person's experiencing violence, now I know that, or okay, tell me everything about that. Like kind of pacing that for ourselves, but also for the persons. I'm really glad that you've told me that. It's a really hard thing to talk about, and we can figure out together what's possible. What do you think it's most important for me to know? Because sometimes people are telling us about violence because it's really important for understanding their AOD use, or they're telling us about violence because they need help right now, today, they can't go home. And other times they're telling us about violence because it's part of understanding who they are, but it's not an immediate thing that's causing them a problem in their life. So I think that's then, after we've done that acknowledgement and validation, then that's where we start to move towards that, what their worries at the moment, like what I want to say, why are they telling us? But I don't mean that you'd ever say why are they telling us, but how does this relate to what why they're accessing the service? So that curiosity about how violence intersects with the thing that people are accessing service about, I think, can get lost when we in that service model of, okay, they're experiencing violence, do you need referral to a domestic and family violence service, as opposed to how unpacking a bit or sitting with how does that relate to why you're presenting to our service, or the kind of care that we're delivering, and also what does it mean for the care that we're delivering. So sometimes it might have implications for what's the safest way for us to contact you, or is it okay for me to call you or text you on this number, or is it safer to have your appointments at the clinic? And I don't mean because, or at the service, I don't mean because of the home visiting policy, but that perhaps there's a way to set up a sort of a safety protocol with someone around accessing services. But unless we're able to sit with that kind of next moment, and again, I'm not talking about a huge domestic and family violence intervention necessarily, but kind of breaking down that initial response into these little moments that make up a bigger moment of thinking about sitting with and unpacking a little bit. What are the things that they're already doing that are keeping them safe? What are the things that they need help with? And from there, we can move into more of what are the things that they already have in place, and where are the gaps? So sometimes people are telling you that they've experienced violence and they actually have a lot of services in place that are supporting with that, which is very different to this is the first time I'm telling anyone, and I don't have any structures in place. And I think that kind of slowing down to engage with women about their experience of services is also important. That it's always important, of course, that we're being careful and making referrals that people are consenting to and want in their lives. But it actually becomes crucial in domestic and family violence that we're checking which services women are already connected to or not willing to connect to for whatever reason. Perhaps in a regional area, a family member of the perpetrator works in an organization, or there's shared files or documentation. So we need to be really careful about how we're deciding what services should be involved and respecting people's own knowledge and expertise in their lives around that. And I guess a big example is the police as well, that sometimes the police are really pivotal in helping women be safe and get safe, and sometimes that's a really difficult relationship. So we need to be really careful in some of those conversations and to seek support, I think, in those decisions. And of course, in this box, it's set up for New South Wales Health, but who are the people that you can talk to around these decisions, and being careful about that so that we're meeting our own service obligations and keeping ourselves safe, but not putting women at risk from our uncertainty as well. Certainly the issues of risk and safety, I'm distracted by the picture there. I should have said all of the pictures on these slides are of my garden, because when I was putting together the webinar, I just couldn't think what was good pictures to have on slides about domestic and family violence. So I just have many photos of my garden on these slides. And this is a spot I like to sit and have a cup of tea and look at the sky. So that's what's distracting me. But I think the idea of safety and risk in the context of domestic and family violence and substance use is really complicated. So we're often sort of expected to have conversations about violence or provide care to women experiencing violence. But how do we really know when to worry, or what is risky in the context of violence? And in AOD services and in my homeland of mental health services, it sort of differs from other areas, I think, because we use language of risk a lot. And actually, in mental health services, our resources are often allocated based on risk, and we feel confident in our clinical judgments of risk to a certain degree. But the risk, I mean, it's a word being used in two quite different contexts, because the risk in domestic and family violence is very different, and harder to sort of determine, I think, in some ways. And in working with the victim survivor group, there were tensions that really rose around shifts towards focusing on safety. So there's a sort of movement to move away from risk and to talk about what are the things that people need to feel safe. But as I already mentioned, it's very hard to feel safe in a context of violence. And some of the women I was working with were very clear that they would never feel safe. And it's very arrogant of a service to think they can help a woman to feel safe. As even long after, if they're to leave violence, there will always be a feeling of being at risk and not very safe. And also, I think for others, there was more of a sense of like, what are the things that I'm already doing to keep myself safe? So that it's another sort of form of structural violence, essentially, to go, these are the things that are risky, and these are the things that make people safer, as opposed to the kind of messiness of that. So I think we have to have some openness to not knowing what keeps people safe, or what the risk is. That often people have learned very complex ways to stay safe, and things that seem to make no sense may serve a purpose. For example, staying in relationships is a very obvious one, that sometimes people stay in domestic and family violence relationships because that's the safest option for them or for their children, and that they know enough about how to manage that dynamic that it feels safer than leaving. And certainly, I'm sure we're all familiar with the idea that the period of leaving violence is often the most unsafe for women. So then when we're thinking about how can we help women be safer, it needs to, again, zoom into the kind of details of that a bit more. How can we have conversations with women about strategies for protection? So things like, have you got some contact details for emergency kind of people or services stored in a safe spot? Have you considered having another set of car or house keys hidden somewhere? Is there a way that you could keep a little bit of money somewhere accessible? Do you have copies of your family identity documents? Even if you feel safe enough at the moment, could we talk about what you would do if that changed, if you started to feel unsafe, or if you needed to leave quickly or get help? What would you do? What would you need to take? Who would you contact? What would be the safest way for you to contact those people? So that if we can help people see the things they're already doing to keep them safe, but to think a little bit beyond that to what else they might need to do, that's generally a safer option than just focusing on how can I support you to leave this relationship. And of course, there may be times that women are very ready and wanting to support to leave, so that's not to dismiss that as well. Generally, research would suggest that women who experience violence are pretty good at estimating risk. They may underestimate risk, and that's really important because that's not to say that they're silly and they haven't, read the room enough, but that the risk is very fluctuating in domestic and family violence. So they may think that they're not at risk, and that's where those conversations about, well, what could we put in place just in case that changed to become really important. But generally, research would suggest they don't overestimate risk. So if someone is telling us that they're worried, we need to listen. And if they're saying they're not worried, we may need to ask a few more questions to help sort of think that through a little bit together. But if people are telling us that they feel worried or they're accessing services seeking help, that we need to really respect that and take that very seriously. So I think then our role in the context of risk and safety, and this is, I guess I'm thinking about workers in AOD services who aren't holding specialist domestic and family violence portfolios. So there is to know how to access those people who have the really in-depth knowledge and skill of risk and safety in the domestic and family violence space, and not presume that we do because we're familiar with risk in a different context. And to think about how can we help people to find that right moment or be ready if it arrives to leave, and what are the things that people are already doing or that we can put in place to help keep people safer in the meantime. And recognizing that sometimes coming into contact with services is a real window of opportunity to help people. So these conversations, even if it looks or feels like nothing changes, can be really life impacting for people in terms of just putting in place the next bit of the plan or thinking through that. The next slide that I'm going to put up has some red flags for violence risk, which been developed by Anne Rose. And I think sometimes people find them really helpful to think that there are things within experiences of violence that are particularly worrisome, but again, it's not this very clear matrix of these are the things that we should worry about and other things we shouldn't. These are also in our domestic and family violence policy in New South Wales Health, but actually a lot of workers are not aware of them. So there are questions that we can ask people about their experiences of violence that go into more depth and can help us kind of untangle some of that experience to get a sense of risk. Yeah. I think they're difficult conversations to have, and it's not always the safest or the most appropriate time, but we need to have enough knowledge that we can be ready to have these conversations, that we feel comfortable having conversations, that we're drawing on knowledge to be able to have these conversations, and that we can seek support from specialist services when we're unsure as well. I do want to acknowledge the changing service context of AOD services, because it's really relevant to this, I think, when we're talking about the ideal versus the reality. And this is something one of the AOD staff said to me, was around how their service had changed. So it started with COVID and moving to kind of telehealth, but then also a whole lot of other factors. So around the types of medications and moving towards a once a week rather than a daily contact, that a lot of services don't have key workers, so people are meeting different staff every time they're interacting. And that all of these things, as we know in lots of parts of our work, flow on to change the nature or the quality of the relationship that we are having with people accessing services. And so therefore, things like, outsourcing dosing or are just meeting people in the clinic, or just having phone contact, or the kind of decreased resources that mean people have to be at a certain point in their AOD usage journey to access support, impact upon the ways that we can support people with violence, which isn't to say we can't. And I think there's a real risk of going, well, it's not safe for us to ask people about violence because we only talk to them on the phone. To thinking about, well, what does this mean in this changed service context in terms of how can we provide opportunities to have conversations in safer ways. So people are not always expecting, I think, to access a service for this purpose and be asked about something different. It can be quite jarring if you think that you're going to just have conversations about substance use and then somebody's asking you about violence. So I think some of that kind of preempting of, it's hard when we just talk on the phone, but there are a few questions that we do like to ask about people's lives. Is this a safe time to ask them? Is there a different way that we could ask them? Those kind of things. I think the other thing that's probably particularly confronting around domestic and family violence is the levels of surveillance that people can live with in their lives. So we all live in a world of technology, and I think we're conscious of this to a degree, but the kind of covert surveillance that can so often be a part of domestic and family violence. And I think in those stats at the beginning, I said, I can't remember the number, maybe 60 or 70% of women had also experienced technology facilitated violence. So that is things like recording devices, baby monitors, or those video doorbells, or those kind of things that mean we need to be very careful about not compromising people's safety because we have limited time or contact with people, and we're wanting to make sure that we have these conversations. Just seen the time, had a small panic for myself, but we're on track. I want to just talk about particularly what those 34 women talked about their experiences of engaging with health services. And they may not all be relevant to you and your work, but I think there's things in this that I found really useful in my own work, and hopefully things that will be useful to you. So many of the women that we worked alongside reported not being asked about violence at all when accessing services, or disappointing responses to disclosures. So the kind of build-up of telling someone about this and then nothing really happening, or it never being mentioned ever again. And I guess a difficulty in trusting services, so that even very trustworthy health workers or services, it's the nature or the dynamics of domestic violence erode trust in people that you should be able to trust, or in services that you should be able to feel safe in. So then the onus is on the workers and the services to constantly, or not constantly is a big word, to have maybe constant attention to the need to build trust and to signal safety and to be trustworthy, rather than to expect people to trust us when they're experiencing dynamics of really compromised trust in people that should be trustworthy. So some things that women talked about in the context, and this was talking about health workers. I know that some AOD services wouldn't consider them health services, and sorry about the language there. But some of the things women talked about were wanting staff or workers to understand the dynamics of domestic and family violence. And I guess that's why I've spent so long today talking about domestic and family violence as a issue, and what the kind of some of the dynamics and experiences of that are. Because if we have enough understanding of that, then it changes the way that we engage with people in whatever way. So it adds this element of understanding of how to have these conversations, or why people may not be telling us about their experiences, or why people may be responding to our service in certain ways, why people may suddenly disengage, or the elements of shame and fear that can go along with having told a service about violence. So sometimes we have a really incredible interaction with someone and they tell us their experiences, and we've responded in all of those ways, all of those moments of validation and acknowledgement, and then they don't come back. And that can be confusing, I think. But if we have enough understanding to recognize the shame and fear that can go along with talking about violence, then it shifts some of how that's understood in our heads a little bit. And I think the other thing around understanding the dynamics was to not assume who experiences violence, that sometimes workers who've been working in these spaces for a long time think that we can kind of get a sense of who experiences violence, but people are incredibly good at hiding their experiences of violence. So that women wanted staff to have understanding so they can recognize signs, but also proactively speak to women about these experiences. They want staff to recognize the links between health and illness, or in this case, substance use and domestic and family violence. So it's relevant to people's experiences, but it isn't all of who they are. So women talked a lot about this kind of either an under focus or an over focus, that sometimes domestic and family violence dominates all of the conversations from then on, when actually they're really wanting to talk about their substance use. But at the same time, to just write it down somewhere and not return to it is very problematic. So this kind of being willing to sit with, how does that relate to the other conversations that we're having? A real focus on this building trust and validating experiences, and that needing to be an ongoing process. And of course, that's challenging in many service settings, but is crucial when we're asking people to engage about violence. And sometimes open-ended questions can really support that. Like, what do you need right now? What would you like to talk more about this? What is the best way for us to keep talking about this? How can we safely communicate with you? How would you like me to bring this up again? These kind of opening up a little bit of space to figure out together a bit of a plan about what to do and how to respond. Even just, can you tell me a little bit more about that? This kind of requires us to stay calm and present in ourselves enough that we can think about people's immediate and longer term needs, and try and stay in the moment rather than leaping towards that advocacy and support. So again, a lot of women are not expecting staff to fix violence. They want to be supported in ways that they need, and for workers to use their power of being within services to advocate for women and to provide support. So all referrals to be collaborative and cautious. So again, that's that kind of transparent talking about which services are safe, and I guess also recognizing systems abuse. So how documenting about domestic and family violence can have impacts for child protection engagement, and be used against people in custody, etc. And so we need to be really collaborative and communicative and seek support around that. So we're clear of what we're doing and why we're doing it. The vulnerability around talking about violence means that follow-up is crucial. So women were very clear that silence doesn't mean they're fine. Like, I haven't mentioned it again, therefore it's not an issue, that people are very much reading the cues of workers of whether this is something they can cope with, whether this is a conversation they're willing to have, whether they have anything helpful to offer. So it should never be a standalone conversation that's not revisited, or something that's just documented and maybe a referral made but not revisited. And the documentation certainly came up a lot, and that will differ across the different AOD settings, but definitely in, I guess I'm thinking about health context of services, that the importance of being careful of what you document so that it doesn't contribute to being used against people in court, or, and sometimes, I mean, it's a difficult thing to just quickly talk about, but I guess that sometimes we document in ways that we've kind of learnt to sound neutral, but that can be problematic. If we say, for example, alleges violence, or just even writing history of domestic violence, it's really unclear that this person has told us that they are experiencing violence. It adds in an element of potential, maybe this isn't true, maybe we don't believe it. Or I remember one woman talking about how it said history of domestic violence in her file when she got it under freedom of information, but that wasn't clear. Was she the victim or the perpetrator? And she was shocked because the violence was ongoing. It wasn't a history of, it was currently experiencing violence. So I think we sometimes try to soften the language, but we need to be very clear about factual about what we've been told and by who, and be conscious of misidentification. So it's often a component of domestic and family violence that some confusion is brought into the mix around who is the perpetrator. And of course, our documentation can't solve all of these problems, but there's certainly a lot of indication that we minimize or don't document at all, or we document in kind of domestic and family violence blind ways. So again, the expectation is not that we're specialists, but we have enough understanding of the context of our services and violence that we can develop ways of practicing and documenting that are supportive of women as well. Women talked about what a good response to, telling a worker about your experience of violence or seeking support for violence. So things around flexible understanding of priorities. So for sometimes it's something that people really want a lot of support with now, sometimes less so. So being able to sort of talk about that and navigate that together, keeping that focus on safety and trust, validating and respecting women's choices, thinking beyond leaving. So, staff having that broader sense of keeping people safe within relationships until people are ready or able to leave. Having some understanding of things that are worrisome and expectations of what we can and we can't do within services. Staff want to guidance. I think staff were talking about this guidance of things to say. So, it's helpful conversation within teams and services of what are the sentences that we can say to people. How can we have clear follow-up? So certainly in all of this work, what we found was that good responses are woven into practice. So a lot of people, of course, are doing amazing things in figuring out how to prioritize safety and trust, how to be conscious of their body and face and trying to say something rather than nothing, and sort of being conscious of the structural issues, but not minimizing the importance of trying to have a supportive and collaborative response around violence. I think I'm coming up to the end of I've got 5 minutes. I'm so sorry, Sally. I saw your face pop up. We'll just flick through these last few slides and then leave you with that to any questions in the chat. But I want to just say, with being trauma informed, this is all about being trauma informed. So, having those understandings of trauma and using those in our interactions is really much more about what I understand being trauma informed to be. So, being conscious of ourselves in the relational space with people who have experienced things like violence, and recognizing why it's really important how we come across and how we understand their ways of being. Ooh, but in this space, there's a particular thing about also understanding structural violence, so all the ways that our services dismiss violence as well. I think these things will stay in the slides for you to access. There's a resource that we developed that you can click on, and when you get the slides, they're available to you.
It was absolutely fantastic. Thank you so much, Sophie. There's so much for us to think about and process, and so many great practical tips as well there. We do have quite a few questions, and I'm going to apologize in advance that we will not get through them all, but perhaps I could just ask one about children. I know we know that your focus isn't on the children, it's what we can do for adults, but do you have any points that you could throw our way in terms of affected children? And there's also a question around, are there any differences in the effectiveness for boys and for girls?
Yes, very interesting question. I think, yes, I didn't focus on children, which is, I mean, there's so much to say about that. I think that, what do I think about children? That certainly when we're talking to women in the consultation and co-design elements of this project, children are such an incredible component of this picture of reasons why people stay in relationships, prioritizing decision making, and certainly we know that children are impacted by violence. I don't think that's probably a surprise to anyone, but I think we still have a social assumption that if children don't see violence or they're not directly experiencing the physical impacts of violence, that they're safe. But the kind of dynamics and growing up in an environment where violence is present in itself can be incredibly harmful to children. But at the same time, child protective services can form a part of violence. So it's a very complicated situation, I think, when we're faced with needing to make a mandatory report to child protection services about domestic and family violence. And I don't think women are surprised when that has to happen with health services. So it's often a reason why people don't disclose as well. But it should never be a surprise, I think, is the thing that people shouldn't come to our service, tell about their worries about children, and not know that they might get a follow-up call from Child Protection Services, or these are the things that I'm going to need to do about it. I don't know about the gendered question, actually, about the difference between the impacts on children of different gender. I'm sorry.
Thank you, Sophie. I think for all of you who've asked questions and haven't had them answered, we hope to see you at our other events in this series. And again, thank you, Sophie.
Thank you so much, Sophie. That was fantastic. And you were definitely the right person to be doing this webinar. And I think everybody on who was online agreed with that, and also had some lovely things to say about your garden. But
Thank you.
I would like to let everyone else know that you can find out more information about our guidelines, which of course this webinar series is linked to, and our other resources at our website there, including our newly released implementation toolkit, which are all free. And as I mentioned earlier, just a reminder again for practitioners out there, our online community of practice for professionals in Australia who work with people who experience co-occurring alcohol and other drug use and mental health is available. And Sophie and Rodney, who is our next speaker on the 26th of August, will be joining us for a panel discussion on the 16th of September. To find out more about that, you can navigate through our website or go to the link on screen there. And I just want to thank you all again for having joined us for this webinar. We hope to see you for part 2 on the 26th of August, which will be with Rodney Vlace, and that will be focusing on engaging adult users of domestic and family violence, concepts, roles and practice tips If you want to watch this recording again before part 2 or share it with any of your colleagues, you can do that at our website, and you can also look at our library of past webinars. But until then, thank you again for joining us today. Thank you again so much, Sophie, and please all enjoy the rest of your day, and we'll see you soon.